Good afternoon. My name is Maggie Xiaomei Luo, and I'm the Associate Director of Development and Communications at NAMI, New Jersey. Welcome again to the NAMI, New Jersey's Multicultural Conversations webinar series, proudly sponsored by AmeriGroup. For 20 years, AmeriGroup has been committed to the health of all New Jerseyans through strategic partnerships with organizations like us, NAMI New Jersey. AmeriGroup is actively addressing social determinants in our conscious efforts to minimize health disparities for underserved and minority populations. NAMI New Jersey is committed to serving New Jersey's diverse communities. We represent the interest of all people affected by mental health conditions, regardless of age, gender, race, or ethnicity, national origin, religion, disability, language, socioeconomic status, sexual orientation, or gender identity. With these conversations, we aim to bring more awareness on the relationship between mental health and culture. Now, today's topic is From Denial to Accountability, addressing systemic barriers in diversity within mental health care. We are very honored to have our distinguished speakers today with us, Yvette Murray and Zainab Khan. And their full bios are available on our website. But Yvette is the president and CEO of YRM Consulting Group. Yvette has dedicated the past 35 years of her life to improving our society by increasing the intentionality of leaders and organizations. Zainab is a licensed psychologist in private practice in East Brunswick. Her practice is dedicated to healing trauma and working with diverse clients, including people of color, LGBTQ communities, and Muslim clients. Zainab currently teaches the Multicultural Supervision course at Graduate School of Applied and Professional Psychology of Rutgers University. As you can see, our two speakers today both devote their professional practice to examining and healing trauma, and their multiplicity of professional and personal roles have really lent some great insights to diversity and equity work. I truly look forward to learning from them. So for the next 40 minutes, Yvette and Zainab will present together. We are going to have a PowerPoint put up. And as we listen, let's jot down questions that pop in our heads and minds, and feel free to send them in through our Q&A box on the bottom of the screen. We will go through them during the last 15 minutes for Q&A session. Yvette and Zainab, we are grateful that you are here today with us, and we look forward to your presentation. So now I will pass it on to you first, Yvette.
I'd like you just to write down, who are you? What identities make you you? So mom, sister, daughter, counselor, friend, an ex. Female, middle-aged, uses glasses, Hispanic. Female, young, joyful. Identify as a West Indian cis woman who is raised as Muslim. My role is as a psychologist, as well as know many with mental health concerns in my circle, Black female educator. So when you think about the list you're putting together, if you could only choose one of your identities, what would it be? And some of you are sitting there right now going, I can't choose. And very often, this is what happens when we're in practice. The people come into our office, or we may go into their homes, and we all make assumptions about each other. We make assumptions about class and race and education. And when we're thinking about this idea of working with communities and or being a member of a community of color, that very often one of the things that we'll find is that there's this disconnect, that somehow my femaleness, my Blackness doesn't show up in a therapeutic setting, and it shows up all the time. So the majority of my practice happens to be folks of color, and partly because there's a level of shorthand that we can do that is not necessarily as easy to do when I might be working with a white clinician. That is not to say that white clinicians cannot work with clinicians of color. But what it does suggest is that if you are living in a white identity, white body, that you probably have some work to do to actually be able to do the work effectively. Very often I'll hear people say, well, there's no one else, so therefore I got to do it. And then my question always is, well, systemically, your organization has not decided to put those resources in. What's that about? If you go to the next slide, like I said, I can't see the slide, so I'm going to assume you went to the next slide. So the first thing I want to talk about is our brain, and our brain is going to be really important. The challenge when we think about our brain is that our brain, like right now, you're actually receiving about 11 million pieces of information, which is just overwhelming. And sort of what does that mean? So when we think about the way our brain works, what's important to remember is 98% of our mental processes actually happen in our reptilian brain. So we're not thinking about what's happening. So it's sort of the idea of putting your hand on a stove. When you put your hand on a hot stove, you don't wait to your brain and say, oh, this is a hot stove, I should move my hand off. You immediately take your hand off. So when we think about communities of color, very often when we are coming into settings, and now I'm going to talk from a patient standpoint. While I'm a clinician, I also happen to be a person that lives with bipolar mood disorder, so I kind of know both sides of the house. When I show up, it's important that people are sort of saying, okay, what's the 2% of my conscious knowledge about who this person is, about who Yvette is? Next slide. And you will get all the slides, so not to worry, you will get everything. So how our brains respond. Our brains are set up to determine fight, flight, or freeze. So when we think about how our brain is scanning the universe, we're making decisions about what's safe, what's not safe. And this is not the what should or shouldn't be. It really is, how do we categorize? And we need to categorize. We're receiving 11 million pieces of information any given moment. You know, our brain sort of has file cabinets, and it makes judgments, it makes stereotypes, because we are trying to navigate where we should be versus somewhere else. So all this starts with our brain before you've even walked in to see a client. Next slide. So when we're thinking about, we're thinking about the science of unconscious bias. The key word here is unconscious, that I don't even know what I don't know. I didn't know that I was making a statement that was not okay. I worked in domestic violence, and people will say, oh, and the rule of thumb, and it's like, I don't know that we should be talking about it in that way, because in domestic violence, what we know is rule of thumb was the thickness of what you could hit your wife, children, and animals with. That's where that term came from. So when we think about the mental categories, our personal experiences are hardwired. I can't be anyone than who I am. So if I've had experiences with certain groups, then I am more likely to either be very welcoming to those groups, or I may be sort of stand back and be a little more put off. That when we think about unconscious bias, it's usually very much triggered by something that's happening in the moment. So recently someone suggested that we should have a powwow. And we kind of looked at each other and went, that might not be a good look. And it may not be language we really want to use, because the language itself is problematic. Then when we think about bias, we're now talking about stress, our time constraints. Did you have a chance to read that file? Did people actually put information in the record that really actively reflected who they are? Do they understand about confidentiality and where that shows up? Our need for closure. Part of the difference in my practice is that very often the closure is very open, and that people are able to come in and out of treatment as they deem fit. And when in the last year in particular, with the murder of George Floyd and COVID and everything else sort of going on, that people very much, and particularly people of color, felt like it's just too much. And many people who live in white bodies and white identities also felt like it's just too much. The difference is that some of us can't look away, that it is our daily sort of experience, and how do you sort of navigate how to manage your world at the same time you're doing your own internal grieving or your own internal hurt. So the next one, thank you. So when we think about, and we're going to talk about this throughout the session, we want to think about how does bias show up and how does structure show up. So we want to start with ourselves. What do we believe? When I used to work at a university, and I believed that walking by fraternity houses with white males was probably not a good idea around 10 or 11 o'clock. Why? My experience is that for me, white males can be scary. They also might be threatening. They also might be drinking. So there's all these assumptions being made, and none of them may be right. But that's where I'm starting with. So when we think about our belief system, we're talking about what are our attitudes, both toward others, toward ourselves, but also our in-group. So it's not, I can't speak for all women who identify as African-American, Black, or Latina, because I just can't. I can only speak for me and my experience. We then move into behaviors, and this is where it starts to get a little itchy. So when we think about behavior, it's what do I do with the information I have? So when we start here, very often people talk about micro inequities. Very often a micro inequity really feels like a macro aggression for someone who actually is experiencing it. So microaggression may be that, we decide we're going to have a cultural heritage night, and you have people from the African-American diaspora who may not know where they came from, really may not. The idea is, oh, I guess I'm bringing watermelon and chicken. Well, that's probably not what I'm bringing. So that fits into it. Also, we start talking about levels of disrespect. And for those of you who are female, very often you will find, no matter what your racial background is, that being female sometimes can get you locked out, asking questions about who leads our organizations. So it's what do we do with the information we have? So one of the things that we found out is in the research is that predominantly Black and African Americans during the opioid crisis did not have the same level of addiction as white folks. Well, why was that? And the main reason was bias. It was bias assuming that Blacks and people of color have a higher pain threshold. It was that we are drug seekers. It was that we were overestimating our pain, when none of those things were true. And this is and if you talk to medical students, this is some of the information you'll actually get from them today about what they think around different identities and the way people sort of show up. Then we look at organizational culture, and this is going to be particularly important if you are both a clinician on your own or if you're in a bigger system. So what does the institution tell you about the people that you work with? Very often in the conversations around Black and brown folks or Indigenous people, it's this idea of lack of resources, lack of adequate housing, lack of employment. And I would encourage you to think about, where are folks resilient, and to start with resilience before we start with lack of. For those of us who have grown up poor, whatever poor is, very often people don't identify that they're economically poor, because ultimately it's about what's happening in that family system. So when we're doing this work, we need to think about the entire family system, not just the person who's sitting in front of you. And then we start in that organization, we start to look at lack of representation. Who's being represented? How are they being represented? And this is not about checking the box. So we need one of these, two of those, three of the others. You want people who are competent to do the work. If you are not finding people, then the question becomes, where are you looking? And it also may be, when we start looking at from a society or systemic position, that there may need to be more resources put into the system, that only 5% of clinicians in this country are folks of color. So when we, living on the East Coast, it feels like, oh, there are a lot of people. Well, the fact is that there aren't, and it's very difficult to find a clinician of color when you're looking for one. And then finally, the systemic issues, and that is what is baked into the system. Who counts? Who doesn't count? Who receives services? How do they receive those services? Do we vilify people for who they are and what they do? So I'll go back to opioids. When people of color were using opioids, they're bad people, that they have no their own sense of self-worth. They don't have self-control. We're going to incarcerate them. When people in white bodies and white identities started using opioids, it was, oh my God, this is a public health crisis. They need assistance. We need to help them. So that alone is how the society and the systemic aspects show up. So we're now talking about industry practices, what matters, what doesn't matter, who speaks, who doesn't speak, and then what are the policies that are being put forth? Does your organization even have a statement really speaking to providing that full range of services to people, no matter where they are and sort of where they come from? So from this, what's important as a clinician to know is that equity work, and when you think about African Americans, and I'm going to really be specific in that space, but it's important to remember that African Americans may be Black, but not all Blacks are African Americans, and they're different life experiences. So when we think about minority stress, the thing to remember is that, and many of you are aware of ACEs, adverse childhood experiences, that this work is at minimum 5-generation work. That you're talking about that in our bones, this information and the stress is being perpetrated and perpetuated within family systems. For the most part, the theory now is that once someone has had trauma, that it can actually go on for 14 generations in aspects of it. The thing about minority stress that's really important, and it's widely researched, is that with minority stress, what we're talking about is something that's chronic, pervasive, and persistent. That when I wake up in the morning, I don't look in the mirror and see a woman, I see a woman of color. That's who I see. My children, when they leave my house, I see children of color, and at times I fear for them, particularly my son, who's 6'3". And a gentle giant. So when we're thinking, and we're going to talk more about this, but it's always important when you're practicing to ask yourself, what is me? How am I behaving based on the information I have? Is this information I have actually accurate? Which is why we should be doing case studies and case consults. And then what does my organization say? If there are no people of color that are skilled in my organization, then the question becomes, okay, why not? What is that barrier? So what I'm going to do now is I'm going to actually flip it over to Zainab, and she will keep it moving.
Thank you. Thank you so much for setting that up. That was so beautiful in how you framed it, because it helps us to talk about, we're going to zoom in a little bit on, and Yvette's going to come back and talk more about some of the individual parts of this, but we're going to zoom in a little bit on the institutional part of what Yvette just presented for this conversation. There's such deep work. So thank you, Nami, for putting it. I feel like we could have done hours and hours on this presentation topic. So as we're just switching speakers, we wanted to just do a quick reflection. And I also put it in the chat, but if you're a provider, what brought you to the mental health world, right? And if you're a family member or a client, what do you hope from the mental health field? So let's just take a second. If you do have access to the chat, you can put that there. But if not, just for yourself, what brought you to the mental health field when we think of mental health? So I'll just give it a second. I know for me, it's really been about healing, right? I think that we now call them therapists, but there's been healers throughout history in all communities. And so, I think, so someone is saying dealing with family and population with lots of mental health issues. So seeing the pain, the suffering of those around us. A system where everyone is heard, understood, respected, support for my adult children, physical and mental health, yes, and sort of breaking these cycles through access, your children, right, to help family crisis, so working with families and education. So you could see there's a theme of wanting to heal and suffer, right? And heal suffering, heal trauma, hope that people get access, taking care of people, and to be understood, to just bring that healing. And why I bring that up is, and next slide, please, is how does these two go together? Oppression, racism, and mental health. Because this is the first thing that I notice in our field, in the mental health field. Somehow we imagine that we're separate from the oppression, separate from the racism, separate from causing harm. And that's actually our first layer of denial, right? That unfortunately, mental health has that intention, has that value of healing, of helping, that we all came to this field for, or were seeking as clients, as family members. And yet it's still, as Yvette did a beautiful job, on all levels intertwined with all of this oppression, all of this racism. And unfortunately, as she gave beautiful examples with the opioid crisis, it has an impact to cause harm. And so the first layer of denial we have to start doing is that it's not in our field, or we're good people, so we would never harm someone, right? Yvette did a beautiful job showing that whether we like it or not, our brain has bias. So if you think you don't have bias, sorry to break that bubble, you have bias. We all have bias. So starting from that lens, the mental health field has bias. Next slide. And Yvette and me wanted to just say that when we talk about oppression, we're talking about all of it, the racism, the sexism, the ableism, and it's any time there's power over those without power. And I think she did a great job about the intersectionality. I can't erase being a woman and being West Indian or Muslim, right? They're all interconnected. And we just wanted to highlight that because we talk, and the reason I wanted to highlight is that sometimes we do focus on race but that's not because people of color are, I think using the race card or whatever is the criticism. That's because those who colonized this country chose race to be the separator, right? And committed genocide, enslaved African Americans, and was very xenophobic to any immigrant groups, whether from Asia, whether from Latinx countries. So that's not us. We didn't create this system, but it is. So I just want to know that we are going to sometimes use race examples, but all of them is connected. Next slide. So while a lot of us usually do things unintentional, we're coming with good intentions, the system of oppression is not unintentional. It is a very intentional, very calculated thing, unfortunately. And so oppression works in three ways. There's first that pressure to conform and comply. And if you're brave enough to be who you are or to be different, there's backlash or pressure to get you to comply. And if not, if you don't comply, you're then villainized and got rid of. And so, for example, if we use the indigenous folks, right? I think one of the news stories that was so heartbreaking was to find, children's bodies buried in these re-education schools, right? So So not only was genocide already committed through villainization of being savages, being different, right? But then there was re-education schools, and then even then there was murder. And so this is purposeful. And if you need a reference, White Rage is a great book to see how purposeful this oppression. And sadly, that oppression is in our systems. Yvette gave the example of the opioids. We also know that Black men were highly diagnosed with schizophrenia and institutionalized. We know at one time homosexuality was labeled as a pathology, and people were given conversion therapy and all these things. It's done now with making our trans folks come to us for gatekeeping. So mental health has been used in a way to harm different marginalized communities. And it's something we have to acknowledge so that we can change it. Next slide. And we're going to talk about a few of these tactics that we kind of talked about, starting with denial. So let's go to the next slide. So let's say you bring up a problem of inequity. You definitely, like, you notice that, for example, certain clients, let's say immigrant communities, are not getting served or not getting as many sessions as your other counterparts, whether that's white or whether that's richer clients, and you bring up that inequity. The organization is going to first start with denial often. And I put that poster because I'm sure every website, every building, I mean, I know we're not going to buildings, but every site has a beautiful poster like this, right? Being welcoming, being inclusive. And yet, when you bring up something, they'll say, no, we value diversity. We have diverse staff. We see diverse clients. There's no problem here. And it kind of then starts getting into a slippery slope. There's no racism. There's no sexism. I don't see color. So that's the first really important, just denial, not acknowledging, not opening our eyes, right, to the inequities that actually exist. And a great reference is, how do we have that cultural humility that Yvette was talking about, to just honor and humble ourselves to know that we don't know everything. And so we do need this feedback. Next slide. Now, if you're brave enough to keep bringing up the problem, keep advocating, you start getting silenced. And these examples I'm giving is stuff I've like genuinely experienced. This topic is not for the workplace. It's too emotional. Go to that webinar. Go do that out there. It's not something we do in here. It's not a priority. And often in mental health places, we're too overbooked. We don't have time for this. And that it's not just the employee, but it's also clients. So if clients are bringing up concerns, they just silence them. They try to just like silence them and silo them, rather than addressing the problem as a systemic level. And we know from, I mean, protests in general, but you know, we have this theme, especially last year, of silence is violence, because it's shutting down any of the solutions we can have. And a really eye-opening book was Race Talk, The Conspiracy of Silence by Dr. Sue, who's done a lot of the microaggression work. He really highlights how race is something that's immediately silenced when we try to bring it up. And I would say for lots of areas of diversity. Next slide. So if you continue, this is the trend we're in right now. I would say in the last few years, we're in this performative acts. So this is from a group, one of a consultant, Inclusivi, you can look them up. But these are 4 ways the organization will try to do diversity. So they will do these presentations, they'll do listening sessions, they'll do special events, which again is great, but the reality, or they'll do like, let's do an hour on DACA students, let's do an hour on LGBT students. They'll try to form little task force, but there's no diversity in leadership, and so no real systemic changes. It's like little band-aids on the cuts, even though you keep advocating, you keep bringing things up. Let's go to the next slide. And then a really important thing that ends up happening is villainization. So if you're brave enough to keep advocating, to keep bringing something up, they'll start to say, you're too aggressive. Why do you speak that way? You don't fit here. I mean, there's news stories coming out from Facebook and Google that African-American applicants are told you don't fit the culture, right? I've also been told, like, if they just said it, then we'll listen, right? A lot of tone policing. And then they try to label you as the problem. And really, this can happen to employees as us therapists. This can happen to clients and family members, right? They'll say, oh, that client's problematic. They just have a personality disorder, right? Let's just push them away. Or they'll say family members, what do family members know? They have no expertise, and they'll push them out. And this is really dangerous. This is something that's done not just obviously in an institutional, but in the world, because it discredits the person and their message, which is their purpose. But then it silences everyone else around them because they don't want to get backlash, right? Or they don't want to lose their job. They don't want to be fired, or they really need to get this mental health treatment. So they're going to keep their mouth shut. But basically, it maintains the status quo. And we have to be careful. If you're seeing villainization and scapegoating happening at your organization, you have to be careful if you're doing it yourself. And a book that's become popular is White Fragility, right? Because when people of color have brought things up, the author talks about sort of the backlash from white folks, but this can also be from any dominant group, men, cisgender folks. Next slide. And if you've survived that, which is a lot, right? The purpose is to try to retaliate, threaten, and get you to leave, right? And it's the same thing that happens in society, right? Whether there's the Muslim ban, whether there's the ICE detention centers, right? They're really, if they're going to make you a problem and get you out. And this is happening in our mental health agencies. And it's fighting, the systemic oppression is fighting true changes. So what do we do? Next slide. What we have to change the narrative is about accountability. That performative stuff is great. Like, I love these webinars. This is how we reach people, we open their eyes, but it's not enough to make true changes. So we have to have accountability in all levels, at the agency, as a community, and individually. And I'm going to focus on agency and community, and I'm going to turn it back over to Yvette for the individuals. So with the agency, next slide. And I love this ladder because it kind of shows you where we're kind of like going from unaware to really working and finding solutions. So the number one thing, of course, is starting with the policies. Like Yvette said, you need to see what your organization is saying. And luckily, most policies, right? Luckily, we're in an age where there are mission statements of diversity. There's always discrimination policies. And to know them and to know what your rights are in your organization and what protections you have. Like we talked about leadership. Leadership is really important because if the leaders of the agency aren't invested, no real change is going to happen. So you have to have them on board. And if there's only like one token person of color, then that's not really going to work. You have to have diverse leadership. And then there has to be an enforcement of these policies, because I've noticed that they don't get enforced, especially if it's a leadership person. If it's someone in leadership that's causing the harm, they're never held accountable. And this is not new stuff. This is all built into your thing. For example, if someone messed up, I don't know, in another way, like really, really behind on paperwork or something, which we've all been, they might get like a verbal warning or a written warning, or you might even get written up. But we don't do these stuff to hold repeat offenders of harm. And I'm not talking about the accidental microaggressions. I'm really talking about people who are causing harms to clients, to employees, and the systemic change. Now, I wish I had like another talk to talk about all the ways we could change systems. But when I ask people, they usually know what's wrong in their organization. It's not a secret. They know that there needs to be better outreach to certain groups. There needs to be better service. There needs to be more flexibility. There needs to be more clinicians. So usually you know what it is. And we need to hear from our clients. We need to hear from the family members. We need to hear from the therapist. That's the only way the feedback is going to change the system. For example, in business, they do 360 evaluations, and we need more of that because our leadership needs to be held accountable to actually make changes. Without this accountability, without actual action steps to move things forward, it's going to be maintaining the system. That's how these systems are, and we know it. And a good reference point is How to Be an Anti-Racist, right, book, which is very popular now because a lot of organizations haven't taken a stance on being anti-racism, so they don't actually hold people accountable. Next slide. And community. Right, one of the bias in our systems is individualistic, right? In the Western mental health, we're individualistic tendencies. So as a group, whether you're clients, whether you're employees, to come together to advocate, that's where your power is. And if you could just hit next on the slide, because a perfect example is NAMI, right? NAMI is a perfect, beautiful place where clients are coming together, family members are coming together to advocate. And the last thing I'm just going to highlight through the next slide to turn it back over to Yvette is just to, I love this graphic, and take a moment to take it in as Yvette's coming on, to see the impact, right? That it's not an individual, it's a system. And if you separate the person from the oppression, from the trauma, from the racial trauma, then you're missing half the story. And I think as agencies, they're missing half the story. And let me turn it back to Yvette to talk more about the personal and interpersonal levels.
What do you notice about the image? Many aspects. What else do you notice about the image? Faces, layers. The image is white-centered. And this is part of the challenge we all face, that all things seem to be in comparison to whiteness. And the fact is that all of us don't live all of our lives sort of looking at where am I in relationship to whiteness? So when we're thinking of, and trying to find an image of color, yeah, good luck with that. It's next to impossible. So part of the question is that shifting and reframing. So what has happened to you versus what's wrong with you? The work that we're talking about really is head, heart, and gut work. So I'm going to say something to you, and let's see what you get. Very first client, I was, brand new minted LCSW. My very first client comes in and says to me, my dad hates niggers, and I just don't know what to do because my daughter is dating a nigger. Now, some of you at this moment have gasped. Some of you have clutched your pearls, and some of you are like, not surprising. And that goes back to that notion of, where do I begin and someone else ends? When I shared this in a clinical meeting, all of my colleagues were like, oh my God, you need to tell them they can't say that. You need to tell, I had a whole list of what I needed to tell them. And I sort of went back and said, they're not here to serve me. My job is to serve them. And it's my job to listen to their story, not the other way around. So when we're thinking about the work, it's really important to understand that we need to ask people who they are. Ask me how to pronounce my name. Ask me if I'm Muslim. Was I born here? What is my ethnicity? Because all of that's going to matter. If I have a woman now who is a Pakistani Muslim woman, and she's looking to be married, and she's going through a matchmaker in order to do that, it's just different. It's not right or wrong. It's just different. So we do need to meet people where they are. And we need to practice. If someone, and the English language is the worst when it comes to letters that are similar to other languages, that if you have a group of clients and they see from a particular area and you have names that are very similar, You need to learn how to say their names. If someone walks into my office and says their name is Bob, I might ask, oh, can you tell me a little bit about how you became Bob? And some people might say, oh, well, I was Robert and my dad's Robert and whatever. Or some people might say, it's just easier. Americans just can't say my name. Or white folks just can't say my name. It is our job to be fluent in other cultures. So I spend a large proportion of my client base happens to be Southeast Asian. So I spend a lot of time learning about the culture because that's my work. That's not ally work. People think an ally means, oh, I got your back. That's not what an ally is. An ally is someone who's done their personal work. You are not looking for people of color to be your Rosetta Stone. That's not the job. You move from ally to an advocate, and an advocate is being able to say, when you see something, say something, and ideally do something. And then you have co-conspirators. These are people who are working together in order to change systems. In order to do this work, you've got to be vulnerable. There's just no way around it. You've got to be vulnerable and also to bring your authenticity to the work. So in my firm, particularly last year, we were dealing with the heightened racial injustice. Now, understand, racial injustice lasts all day, every day. And I experienced that all day, every day. But things had gotten to a place where I was unable to perform. I needed time out. I needed to tap out. And I work at a firm where, we very much, encourage everyone to do that, but we very much encourage our staff of color to tap out when they need to. Because again, that many of us are holding not just what's going on with the client, but we're holding our own stuff all at the same time. And it can be very damaging and overwhelming. That when we're thinking about language, for some people, the language of BIPOC makes sense. So Black, Indigenous, people of color. For other folks, it's like, I don't like that term. I want you to call me who I am. I happen to be an Afro-Cuban woman. That's how I want you to speak to me and how I want you to see me in the world. So we can't assume what other people think or see or feel. We've got to get down into it and be vulnerable and be wrong. Because guess what? You're going to be wrong all day, every day. That's just the nature of our work. But it also is being humble and being able to say, I said XYZ and I thought about it, and that may not have been the best way to frame that. It also is not always to necessarily hear your own voice. So how do you use your power, privilege, and position? Thank you. So the first thing is you have to do your own work. Again, that's about being a conscious ally. It's you do this work for yourself as much as someone else. When we think about this idea of equity, equity is not about giving something up. It's about sharing in the sandbox. And very often when people in white identities hear this notion of equity, it means, oh, I must lose something. I've got to give something up. And that's not what it means. Working through your feelings of guilt, shame, and defensiveness, that needs to happen before you walk in a room with someone. If you are working with clients or consumers and the conversation of race or ethnicity and culture don't show up, ask. If there are things that are happening in the society, ask. One of the things many of my clients will say is, I can talk about anything here. I couldn't talk about these things with a white clinician because it'd be my job to train them. And I don't want to use my time and my money to train them. So we've got to do this stuff together. And to be quite frank, webinars are great, but this is not where the work's done. The work is done in experiential environments where you're looking at case studies, you're practicing the work, you're getting feedback from other folks. Because if this is the only framework you're using, what ultimately winds up happening is you have knowledge, but you still haven't done your heart and your gut work. The narrative belongs to the client, not to you. So again, you may say, oh, they came from a poor environment. They may not identify their environment as poor because poor is a relative term, just like middle class is. Suspend judgment. It's important for us to deeply listen to the lived experiences of the person that's in front of us. And that may include the experiences of their wider family. Trust your client's story, even if it doesn't make sense to you. Do your best to avoid stereotyping, trivializing, or infantilizing racialized experiences. This happens all the time, where someone might say, I feel like I was being discriminated against because I wear hijab and I cover. And you have a clinician who will say, well, maybe it wasn't that. Maybe it was these other 7 things. We need to hear our client and how they process the information. Recognize that all conversations do not require your comment. That silence is golden in this space. Advocate for dismantling and deconstructing white supremacy within your organization, which again is that hard, tough part. And unapologetically call out racist and discriminatory remarks, behaviors. This is that piece that Zainab talked about of being brave. And understanding that being brave means that other people are brave around you. That's how you become a co-conspirator. That you're not going to let the person of color in the room be the one to always bring up when harm is done. You will bring up when harm is done. Acknowledge when you're wrong, and don't expect a thank you. This is the work. This is the work we've signed up for. This is the work that hopefully we're able to get a deeper and deeper knowledge of, so that we can be better practitioners. So I'm going to turn it over to Maggie.
Thank you so much. Truly, I kept taking notes because there's so many new vocabulary and truly, I thank you for the onion peeling presentations, both of you. Zainab and Yvette.
Yeah, Maggie, I just want to let folks know we have provided resources for you. So when
Absolutely.
you say, I have no idea where to start, that's probably going to be a non-statement once Maggie sends everything out. So Maggie, I'll turn it over to you.
Yes, thank you so much. As we wrote on the slides, you can see that we have prepared tons of resources and the books that are recommended by both of our speakers. And truly, we were just thinking when we were planning for this webinar, is that how we, what led us to this dialogue and this conversation, because this topic of systemic oppression and denial versus systemic denial to and all sorts of levels that we try to wrap our head around it. But truly how this came about was it was inspired by unanswered questions from our previous webinars in the conversation series, where we involved our grassroots families and individuals with lived experience to really talk about what we experienced as a community, and such a diverse community. But then there was another level, like a higher level, where we feel hands are tied and we do not know how to express it even. So that's what I was trying to say, that just the past 45 minutes is truly an inspiring and educational presentation, where both of you have done this onion peeling for us, to really help us to have a deeper understanding of what we experience, and also giving words. I learned some new vocabularies as well to express this oppressions and difficulties that we see in the therapeutic setting, and truly empowering messages, I'll say. So I have been monitoring the Q&A area, and I wanted to say that we have some questions that came through. I am going to start with this one, okay, from one of our grassroots multicultural program members and volunteer leader. And this question is for Dr. Khan. So from Pew Research Center, 60% of the global Muslim population is in the Asia's Pacific region, like Indonesia, India, Pakistan, Bangladesh. And in your practice, have you found that the cultural identity issues or struggles of these Asian Muslims, or in general terms, right, how they're different than Muslims from other culture and ethnic backgrounds? Yeah.
Thank you for this question. As I directly messaged this participant, this seems like a whole presentation. And maybe we have to plan it. I will say, and I also I will send a link for Dr. Anita McLean, who's one of my supervisors, doing a 3-part series for CE credits on South Asian families. But yes, I do think religion is one layer, and then culture is another layer. And so there are similarities in terms of some religious practices. However, each country, I would say, not even just South Asian, but each country brings unique struggles, brings unique challenges. And then what level of acculturation are they, did they just immigrate? Are they first generation? Are they second generation? And so, yeah, I do think that there are unique struggles, including sort of like how to balance family, right? And their own individualistic stuff being in America, right? Because I'm treating them here in America. And that expression sometimes comes out different than, like, let's say my Arab clients or my African-American Muslim clients. So I do think that that's a whole presentation, and I will drop the link for Dr. Anita's presentation in case anyone's interested. But I would love to maybe even plan with NAMI if we want to do something on this topic. But thank you for those questions. It's kind of like it's a therapist answer. It depends, right? Like, it's such a specific thing. Like Yvette was saying, that who is in the room in front of me has such a unique layer of factors that could be influencing them at that time.
And I just want to
Thank you
make,
so much.
yeah, someone put in the chat box that, where is it? That the term rule of thumb is a mathematical term. Again, it depends on where you stand. That language can be very different depending on who you are and what your life experience is. So there are multiple ways that a word can show up and mean very different things to very different people.
Thank you for that clarification, Yvette. And thank you so much for the answer, Zainab. And I know that one of our participants have posed a question early on in the presentation. So some of the slides have actually dealt with it to some level, but I would like to give you both the opportunity to comment on it, maybe kind of like a wrap up. So one of our attendees asked that, so how do you reverse or deal with micro inequality to promote long-term change? So it's such a broader term, but wanted to still float it if you want to comment on it both.
You want to say it again, Maggie? I think
Yes, it's a short question, and it was posted when you were presenting Yvette early on in the presentation. So how do you reverse or deal with micro inequality to promote long-term change? So I think that it's really
oh, I got it. When I see it, I call it, and I know I'm going to wind up in trouble. And when I get in trouble, I say, well, gee, why am I in trouble? And really push back on why are we not having, so again, that my first client, who happened to be this white client, I saw it very differently than my white colleagues happened to see it. But it's about the pushback. It's about saying, why is it that we are not, well, COVID, sans COVID, but pre-COVID, there would be questions about, well, why are people coming with their whole families to therapy? Why aren't they just coming by themselves? That in itself is a cultural lens. And so a lot of it is being an observer, and then as an observer, not making assumptions about what you think you're seeing, but to ask what you think you're seeing. Because it could be very, very different than what the person is sort of saying. And I agree, Zainab, my particular client, who happens to be Muslim and Pakistani, she's very clear. She wants someone who's Pakistani and Muslim, not one or the other. So again, really being able to listen. Zainab, I'll turn it over to you.
Yeah, no, you did a great job. And I would say, in terms of the micro inequities, is what Yvette says is keep bringing it up and highlighting it, because one of the challenges that I was trying to highlight is there's always a rationalization, there's always an excuse. So you want to just collect the data on it sometimes, right? And using the client's voice, I think holds power sometimes over us as therapists. So as clients advocating, I think that helps, because when I've worked in a university like Yvette, when students got together and complained about certain things, they were able to hire more clinicians of color. So don't underestimate the work of coming together and advocating. And just pointing it out, because again, that denial, that silencing is like the first response you start to hear.
Yeah, I mean, I think the takeaway, and I would really encourage those who are on the webinar today, is just take the next few days and observe. Observe your surroundings. Observe who shows up and who doesn't show up in both in your professional and your personal life. Who shows up? How are they centered? Whose stories count? When you're writing your clinical notes, are you saying what the client said, or are you reinterpreting what you think they said? So those are all going to be ways for you to kind of figure out just where are you on that diversity scale. And then from there, you can sort of say, okay, where else do I need to build competency? And that's our job. I mean, at least as a social worker, part of our job is to be competent. And if I am practicing outside my scope, and I'll be really honest, I think most clinicians who live in white bodies and white identities working with folks of color are practicing beyond your scope. You were not trained to do that. If you were working with someone who needed sign language and you don't know ASL, they would not be your client. So asking yourself, why am I here? And if the answer is, well, there's nobody else, you've hit the systemic mark, you've hit it right on the nail. And again, I think we all can do certain things, but I'm not qualified to work with certain clients, and I need to be honest about that.
Yeah. And one thing I just want to highlight that was beautiful, and that's why I love doing this webinars, is Yvette's observation that the graphic was so white-centered. I've used that graphic to do a lot of LGBT and trans presentations, and I was really blown, like, wow, I didn't even see, right, like that it was sort of white-centered. And I think like that's just how our mind has to be, open to learning, non-defensively open to learning, because I would love to, I'm just going to add it to my presentations now, Yvette, like, do you notice that bias right in this graphic? So thank you for sharing that. And hopefully that's a model of like how we're continuing to grow, continuing to learn.
Absolutely, absolutely. And thank you both for modeling that learning journey for us. And also, because I know that you have really devoted your time and professional experience in doing this type of digging in. And so that saves us a lot of time and heartache. But you have also shown amazing support and empathy for the provider community, because sometimes we have heard peers in the system who are being providers, and they're feeling that their hands are tied. And just like Yvette was pointing out, that we all are really trying to, we came here with a good why and good intention. And then we just found places where we hope that we will be better equipped, and that is where, we all learn to have this growth mindset, right? I really love, both of you have touched upon this positive sides of it. I love, Yvette, you were talking about how we should really start off with talking about the resilience of the community, the strength in us, the strength in person and the family, instead of starting off with the lack of, right? So that's enlightening. And also for you, Zainab, you talk about how we all have biases, and therefore we have the power to actually help with the healing process. And that really is very inspiring. And I think that this topic on the systemic oppression and denial is not a finger pointing one. It's really an empowering one, because I'm truly grateful to learn from you both that true changes actually can take place on all levels, and start from our individual level as well, as community members, because like Zainab, you are pointing out, NAMI truly is a community coming together to advocate. And we strive to have that level of open-mindedness as well, because sometimes when we all come in with biases, we represent a small subset of the society, right? Where we ourselves need to be educated on learning, having this open-mindedness. So
And
thank you
Maggie,
so
I have a
much.
second homework for them. One, just notice your
Okay.
environment. And then two, ask yourself, how is my organization feeding off of the community? How is my organization benefiting from people being ill? Because very often our jobs, our grants, everything is tied to making people unwell. And in Black and Brown communities, we are very often identified with very serious psychiatric issues. And when you look at people who are incarcerated, over 60% of them have some kind of trauma in their background. So just ask yourself and go back and ask your colleagues, how do we as an organization feed off the community? And that'll get the conversation started, if nothing else does. Hopefully you have some co-conspirators, so you're not the only one. They can't fire all of you.
Yes. Yeah.
Thank you, Maggie.
That's a powerful question.
Absolutely. Wow. We know that we all are busy, but sometimes priorities would lie in these questions. When we ask the right questions, our life will be much more efficient and effective, because I feel very empowered to effect change in the system as just one member of the community, because at the start of the presentation, when Yvette asked us to share what are our roles, you can tell that the multiplicity of the roles that are represented in the room. So thank you so much for joining us today. And thank you so much for our both speakers for joining us and share with us the valuable information. In closing, I'd like to remind everyone that it would be appreciated if you could complete the survey at the end of this webinar so that we can incorporate your feedback for future webinars, because this webinar itself came from your feedback. So we also like to thank our sponsor, AmeriGroup, again, for partnering with us so that we can have these conversations. And so for this hour, again, I'm sure that there's room full of people being thankful to you, Zainab and Yvette, and we hope that you will join us again. Okay, so like we said, we are going to post the PowerPoint presentation, this recording, as well as the book list that are recommended by both speakers. So this concludes our webinar. Thank you so much for joining.